Welcome everyone to the COVID-19 webinar. We are thankful to you for the opportunity to have your time. We hope to provide helpful answers to your question in this 1 hour. I am Dr. Nidhi Rahatgi, an internal medicine doctor at Stanford Hospital. Most of my family is in Delhi, and COVID has affected my friends and family as well. For this webinar, over 6,000 people registered, and we received over 1,000 questions. We read each of those questions. Given we have 1 hour, we will not be able to answer all the questions, but in the next 5 minutes, I will try to answer a lot of common questions with very quick answers. And then our panelists of expert doctors will dig deeper into some of the most important questions. The most common questions that we were asked were on vaccines, medicines for COVID-19, and the signs and symptoms. Please continue to send your questions through the chat box as well. Oxygen levels. So we think oxygen levels of 90% and above are good enough as long as the patient is not breathing too fast or looking too sick. We ask our patients to keep an eye on their oxygen level at home, and if they start breathing too fast or the oxygen levels are dropping quickly, then they should get more help. Fever. We tell our patients that if they have a fever, a temperature of 99.5 or over, then they can take Dola or paracetamol or Tylenol up to a total of 4 grams in 24 hours. We don't want them to get dehydrated fighting those fevers. We have not used steroids for breaking fever, and we will talk a lot about steroids with our panel of experts. In general, how a patient looks is more important than any test. If someone is breathing fast, feeling that they're not getting enough air, they have very less energy, they're making dark urine, or are very dehydrated, it can tell you a lot about how sick they are. If the patient has turned blue or gasping for air or breathing too shallow or has passed out, that means that they're really very sick at this point. Black fungus or mucormycosis, we think that it is likely due to too much steroids, and we will discuss a lot more about that with our panel. RT-PCR, depending on the local laboratory, the nasopharyngeal swabs, nasal swabs, or the oropharyngeal swabs, and even saliva tests are okay. RT-PCR may sometimes be negative in those with an active infection. The symptoms are more important. Chest X-ray or CT scan. We do chest X-ray for those with oxygen levels of less than 94% without the need for additional oxygen. We rarely did CT scan of the chest, only in those whose oxygen levels are just not improving after a few days or they are breathing extraordinarily difficult. We do complete blood count, kidney and liver tests in those who are needing oxygen when they first see a doctor. After that, if these first blood tests are okay, and the patient is doing okay, we don't repeat these tests. C-reactive protein, D-dimer, and lactate dehydrogenase or LDH. Because the values of these tests can be unpredictably high or low in patients who are very sick, these are not essential tests. How sick the patient looks and how much oxygen they are needing are much more important and helpful. We did not do interleukin-6 levels for our patients outside of research. Remdesivir, we used it only for those with oxygen levels of less than 94% without additional oxygen. It is not a life-saving medication, and it is okay if you don't get it. Steroids, we will talk a lot about steroids, but we advise it that we gave it to our patients only for those with oxygen levels of less than 90%. Ivermectin, favipiravir, and fluvoxamine. Because at this time, there is not enough data to show if these are effective medications, and there could be a potential for harm, we did not give it to our patients, even when remdesivir was not available in some of our hospitals. Convalescent plasma, we used it very rarely. It has to be given very carefully and would not recommend it being given at home. Tocilizumab, we rarely use it for those who are extremely sick. We will discuss a lot more about medications with our panel of doctors. We will also talk a lot about vaccines with our panel. At this time, we don't have enough data to know that if mixing different types of vaccines is okay or not. But so far, it appears all the current vaccines are effective against the variants, but they may not be 100% effective. And COVID-19 can happen despite the vaccine. But these vaccines may still prevent severe illness or death. We have posted a lot of resources on our Stanford Global Health website. We will put a recording of this webinar on this website also. Based on your requests, we will also put some of the suggestions for treatment on this website. Which day, what test, which medicine, what to watch out for in patients with mild, moderate, and severe disease. I will now pass on to Dr. Sameer Dwivedi, Medical Director with the International SOS and a family medicine doctor based in Delhi. Thank you, Dr. Dwivedi, for joining us today.
Thank you, Nidhi. Just to give you a brief of what's happening here in India, we're facing a very difficult time. It's a very challenging time for us here. The COVID cases have spread like wildfire, and there's been a very steep rise in the number of cases. Initially, the metro cities, the bigger cities were involved, and now it appears even the small villages are being affected by this condition. We are to be blamed partly. We celebrated too early. We let our guard down, and we had our elections and our Kumbh Melas, and this is where we are. And now our healthcare system is overwhelmed, and the beds are full. We are running out of oxygen. It's remdesivir and medications such as tocilizumab. People are running about and trying to procure them. They're difficult to come by. Delhi, Mumbai, and Bangalore, these were the major cities which were actually affected by this. Delhi and Mumbai seems to be coming down a little bit. And then we had this additional problems of these so-called double mutants and triple mutants, which appears to be more transmissible. And this has really caused havoc. And the thing is that in India, the genomic surveillance is not really very good to be at least be able to understand what is the kind of what are the variants which are actually prevalent. I think the minimum that I think we should do is at least 4 or 5% of the positive cases in a country like India, which is which has 1.4 billion people. Vaccination is another issue here. We've opened up vaccination for everyone who is 18 years and above, and we are in short supply now. A lot of vaccination centers are running out of vaccines. And finally, the international community has taken note of what is going on in India. There's a lot of help coming our way, but it's going to be a few weeks before it kind of reflects on the ground. The thing is, the urgent thing right now is to vaccinate everyone in India so that provided replication is kept under check, we don't have, dangerous mutations coming up, and so they escape the immune system. And it is not just for India; it has, as you know, implications for the world. So I would say vaccination probably is one of the most important things right now on everybody's mind. And we are short of vaccines here in India. Thank you, Nidhi.
Dr. Sameer, thank you so much for the introduction. Dr. Rohtagi as well, thank you so much. My name is Errol Ozdalga. I'm one of the medicine doctors at Stanford. I'm an inpatient general medicine doctor and oversee communications. And I have the honor of introducing the rest of our Stanford faculty that'll be with us today, all of whom you can see on your screen right now. And I'm going to do that briefly in order to save time. We have a lot of questions to get to, and we're really excited to get to these questions. I just simply want to say thank you so much for being with us today. We know how busy you are right now, and to take the time to even be with us means a lot to us. So we'll do our best to answer questions and support you in every way possible. To start with us today, I have Dr. Neera Ahuja. Dr. Ahuja is a clinical professor of medicine, and she's in charge of our inpatient general medicine doctor group, our division of hospital medicine, as well as the medical director of the general medicine inpatient wards. We have Dr. Aruna Subramanian. Dr. Subramanian is a clinical professor of medicine and of infectious disease. She's an infectious disease specialist. She's the chief of the immunocompromised host disease group. And she's very involved with research, particularly along COVID, as well as long COVID, or the effects after COVID and long haulers. We have Dr. Angela Rogers. She's the Associate Professor of Medicine for Pulmonary and Critical Care. So she's a lung doctor and a critical care doctor. She's the Associate Director for Pulmonary Critical Care Fellowship, the Associate Program Director for Internal Medicine, our residency program. And just to give you a sense of how esteemed I feel our panelists are, along with Dr. Rogers and the rest of our panelists. Dr. Rogers was awarded the Physician of the Year during the pandemic, the highest award a doctor can get at Stanford Hospital. We have Dr. Linda Barman. She's a clinical assistant professor of medicine, and she's the director of our outpatient COVID clinic, as well as our urgent care clinic. She essentially is our expert that helps take care of all our COVID patients that are not hospitalized. We have Dr. S.V. Mahadevan, or Dr. Maha. Dr. Maha is a professor of emergency medicine. He's also the director of South Asia Outreach Center for Asian Health Research and Education, as well as the director for Global Affairs and Strategy for Stanford School of Medicine. We have Dr. Kari Nadeau. She's the professor of medicine and pediatrics. She's the director of the Sean Parker Center for Allergy and Asthma Research. She has extensively been involved as well with a number of research for COVID this past year, and is an expert in vaccines as well, has been a key person educating our community and abroad, as well as a consultant for our FDA that helps approve a lot of our vaccines and medications. And you've already met Dr. Samir and Dr. Nidhi. I'm going to go straight into questions. So as Dr. Rattagi had mentioned, we received over 1,000 questions even before this webinar started. We will do our best to get through all the questions. We review them in advance, and we put the similar ones together, and we will go topic by topic to every question and definitely emphasize the ones that came up the most. We'll do our best also to address questions that are coming up live at the same time. So our first question, I'll start with Dr. Rogers. We're going to talk a little bit about the early stages of detecting and managing COVID. Dr. Rogers, how would you go about identifying sick patients, particularly patients in the rural areas? One of our doctors from India mentioned that 70% of the population is in the villages and rural areas. Can you give some advice along those lines?
Yeah, on this front, I really agree completely with Dr. Rahatki. In her introduction, she mentioned that the most important thing is how the patient looks and what their oxygen level is. And so I do think having a home oximeter where you can carefully monitor your loved one and make sure that their oxygen is safely over 90 is important. And secondly, do they look like they're working really hard to breathe? If they're breathing comfortably, their oxygen's 92%, then that's a person that I feel okay watching. If they're looking like they're breathing like they just went running, they're taking deep breaths, having to use the muscles in their neck and working hard, that's a person that I'd really, really want to get in to be seen if I could. And also that person more likely needs oxygen. If you don't have an oximeter at home, that's someone I'd be much more worried about. And we use those same measures, to be honest, when we're at Stanford Hospital and have all sorts of resources. I care much more about how the patient looks than I do about their lab numbers.
Thank you. Dr. Maha, as an emergency doctor, some people do okay for 1 to 3 days and then suddenly get very sick. How should we identify early stage in which patients may get sick versus do better?
Certainly. So identifying potentially sick patients starts with identifying risk factors for severe disease and then monitoring for respiratory decompensation. So the risk factors that we think about are primarily older age, so age greater than 65 or age greater than 55 with any comorbidities, comorbidities themselves like diabetes or chronic kidney disease, cancer or immunosuppression, and then other conditions that you may not ordinarily think about as putting you at risk, like being obese or being pregnant. Once a diagnosis of COVID has been made, then we tend to screen our patients for these different conditions. And then once we've sort of assessed for these risk factors, as Dr. Rogers had mentioned, it's really about monitoring a patient's symptoms, what they look like, and their vital signs. And that's going to help us decide whether they could be monitored at home or whether they need to go to the hospital.
Thank you very much. Dr. Huja, we oftentimes have patients who have persistent low-grade fever. Can you comment a little bit on that as far as things you'd be worried about and things that to be considering?
Absolutely. Thank you, Dr. Ozdalga. So fever puts us at risk for dehydration. So the management of fever should include hydration. And then it is safe to take Tylenol if there is no significant liver disease, or anti-inflammatories, NSAIDs, ibuprofen, Advil, or the versions that you have there, as long as there's no significant kidney disease. So fever management is important, but of the different medications, I would say hydration is the most important.
And can I add on that, one question asked, on days when I feel feverish and fatigued, what more can I do besides steam and rest? Anything else besides what you just mentioned?
I think those three things would be the mainstay.
Great. Can I also ask you, and then I'll ask Dr. Subramanian as well, your take on steroids at this point? Someone's at home and they're having symptoms. Any role for that in your opinion?
You know, and I'll address, and Dr. Subramanian, please add on. We don't recommend steroids if there is no significant oxygen need. We pair the steroid need with oxygen need. So if they're at home and oxygen levels are okay, no steroids, because the risk of harm is greater than the risk of benefit.
Excellent. Dr. Subramanian, can I also get you to comment on that?
Sure. I think in this case, when people are at home, you know, really less is more, and there can be harm, as Dr. Ahuja said, from giving steroids at this point. And we're going to be talking about secondary fungal infections and other risk factors, you know, that complications that can happen when you give steroids at this point. So I really think I totally agree with Dr. Ahuja at this point. It's really paracetamol, brufen, fluids, and really good nutrition, taking rest, and no need for antibiotics at this time, no need to really go after getting all sorts of other medications, and getting a pulse oximeter, as Dr. Rogers said, to keep at home and keep an eye on really your oxygen levels are what's important at this time.
Dr. Subramanian, you mentioned Tylenol, paracetamol. How about piroxicam? That was one question as well. Any issues with that?
Yeah, I think any non-steroidal anti-inflammatory can be safe at this time, as long as people have, you know, they know they have normal kidney function or they don't have other risk factors. So I think, you know, we encourage people to take these types of medicines and take rest.
I just wanted to, Errol, I'm sorry, just wanted to add out here that, you know, not so long ago, there were these scare stories about NSAIDs based on a study that was done in Korea. It was a retrospective study, and it's a small study that showed that if you took any of these anti-inflammatory, the chances that you would deteriorate is more. This, I guess, has been put to rest now. Just wanted to make this, you know, highlight this area, because a lot of people still have concerns regarding taking NSAIDs in India. Yeah, thank you. Sorry.
Thank you, Dr. Samir. And perhaps Dr. Subramanian, can I also get you to comment? One question came up, patients at home, they're relatively doing well. Is there any indication to get labs done, inflammatory markers checked?
We don't really recommend that at this point. You know, it doesn't change your management, and we have to remember that most people do get better. You know, if they have fever and mild upper respiratory tract symptoms, they do get better with rest. So there's no need for those markers unless they're getting worse.
Thank you. Moving on more to home management, Dr. Barman, as an outpatient COVID doctor, you oftentimes may have patients who feel short of breath, but you know that they're otherwise doing well. What things are you thinking about? What recommendations do you have to manage these patients?
That's a great question. And I see a lot of my patients are short of breath, very, very common. If they do have an pulse oximeter, that is really helpful to get a concrete number. If the number is good, that's reassuring. And we do monitor most of our patients remotely, either by phone calls or video, and found it safe to do so in most circumstances. If someone is reporting a low pulse oximeter number, the first thing we actually verify with them on the phone, on video if possible, that number is correct. As we have a lot of patients will get the pulse number and the pulse ox mixed up. They might have, we educate them to put it on a couple different fingers. If someone is feeling short of breath and is having significant chest pain and has a cardiac history, we're not going to waste time. That could be a sign of a cardiac event, regardless of pulse ox. If they actually look and feel pretty well, I will have them at home. We do what we call an ambulatory pulse ox. Okay, check your oxygen level right now. You're sitting down talking to me. It's 95%. That's great. And then I have them stand up and just march in place and check their pulse ox to see if that's dropping. If I have any concerns, if they are having other symptoms such as feeling dizzy, severe fatigue, difficulty walking around, difficulty doing their activities of daily living, or if their oxygen levels drops when they're walking, I'll bring them into clinics for further assessment. We do sometimes do EKGs or possibly chest x-rays. I do find in a large amount of time, the workup is negative. And part of it is knowing about COVID and the severe anxiety associated with it. So we do spend a lot of time reassuring patients.
Great, thank you very much. The next question I want to spend a little bit of time on because it was a very common question. Dr. Rohatgi, I actually might ask you to comment first, as well as Dr. Rogers and others if they'd like to. But the big question that came up often is the need and use of someone for oxygen at home, and what thoughts and recommendations we can have along that. I know many of the doctors on this webinar have had multiple regular conversations with doctors in India about this issue. What practical considerations can you recommend or say about this?
Thanks, Dr. Zalga. I think the first consideration, as Dr. Barman mentioned, is that reading accurate or not? Second, as all of us are mentioning, is that it's very important to see how the patient is feeling and looking. That is much more important than the number. There are lots of difficulties getting oxygen in India, and I would also want to emphasize that we don't have to be 100% on the oxygen. 90% is okay. If the oxygen levels are dropping quickly or the patients are feeling worse, those are the things that worry us most than the oxygen level of just 100%, 90%, or 96%.
Thank you. Dr. Rogers, can you also, any additional thoughts?
Yeah, I wanted to just acknowledge that what we're talking about here about asking people to take care of people on oxygen and watching them, especially if you're not a medical expert, is really hard. And we want you to know that our hearts really go out to you. We know in the United States, there were hospitals that were also really stressed and the feeling that you couldn't give the care you wanted to because of a lack of resources. And you're in such a terrible position trying to give the best care to your loved ones when the home is not the ideal place to go when you have a new oxygen need. But I agree 100% with Dr. Rohatgi that if the oxygen is 92 and the person looks good, that is good enough for me. And so you can have the oxygen last longer by targeting those lower levels. That's what we do in intensive care as well. We do not need to see high 90s. I know that on Dr. Rohatgi's site that she has posted that there are instructions about proning where you spend a lot of time lying on your stomach. And I can say that even in intensive care unit, we found that there were a lot of patients whose oxygen got markedly better when they were in that position. It just improves the place where the gas is going and your blood is going and seems really helpful. And so we had patients that almost needed a breathing tube. And if they just spent a lot of the day on their stomach, their oxygen levels were better. So I think that's definitely something to try. And then the final thing that also Dr. Barman mentioned is that oxygen levels do drop when you walk. And so if someone is really teetering, very, very sick, you can't get them to a hospital, they're in the 90s, trying to limit the amount of things that they have to do physically, they will be lower when they're walking than they are when they're lying. And so as much as possible, if someone can get them their things and limit that, that would be good. And if they happen to have CPAP at home, if they have other medical conditions where they have those machines and have a mask that fits, again, it's not ideal. If there is a hospital you can go to, it would be much better to be with someone who can watch. But that is a strategy that is used in many countries, even for people in a hospital. We tend to use something called high flow, which wouldn't be possible, but that will usually get you some extra time and get a little more oxygen in.
Great. Dr. Maha, could I ask you to comment as well?
Yeah, in addition to what Dr. Rogers is saying about proning, in addition to laying on your stomach, you can also lay on your left side or your right side and actually rotate those positions. And that's been found to be beneficial as well. And as Dr. Rogers is suggesting, you're recruiting different parts of your lung to be useful, and people tend to feel a lot better, and their saturations tend to rise even without getting oxygen applied.
Great, thank you. If there's no other comments along those lines, and we can come back to that as well, as a lot of this is overlapping, I want to take a deeper dive into treatment and spend a little time here. As no surprise, this was a big area of questions. And I want to start off with some of the most common treatments that most people are aware of, remdesivir. And Dr. Rogers, perhaps I'll start with you, and then Dr. Subramanian. As far as when should remdesivir be started, who should be getting it, and just some general thoughts on that.
Again, I agree with Dr. Rohatgi's comments at the beginning that remdesivir, that Dr. Subramanian was one of the key authors on one of the largest papers on remdesivir, so I should really defer to her. But it particularly shows a getting out of the hospital sooner if you're in the hospital, and was less clear that it helped people live, survive better. Whereas dexamethasone is really very much our standard of care only for people who have oxygen, less than 90 or 92%. If you actually need oxygen, then steroids helps people survive. On the flip side, as others have said, if you don't need oxygen, there was actually a trend toward harm from getting steroids. So I do worry that in the desire to do something when you're sick, that people are taking a fair amount of steroids and maybe actually increasing the risk of their loved ones. So we really have a line in the sand where if you don't need oxygen, no steroids. If you are needing oxygen, then yes.
And Dr. Rogers, thank you for pointing out, Dr.
Well, I just wanted to add out here that in India currently, the steroids that are currently being prescribed is mostly methylprednisolone, whereas most of the data that we have from the literature that we've seen is with dexamethasone. But what the doctors here tend to prescribe more is Medrol, probably from clinical experience that it works a little better than dexamethasone. Would you be able to comment something on that, Angela?
Sure. Decadron or dexamethasone is not in our ICU experience our go-to drug either. We tend to use, as lung doctors, a lot more prednisone, and methylprednisolone is more our norm as well. But one thing that is notable is that it's not a lot of steroid that's being, the Decadron dose was not super high in the big recovery paper that changed all of our practice. And so I would just be trying for an equivalent low dose, sort of a modest dose of steroids, not huge vasculitis type dosing. But I don't feel strongly about one over the other, but maybe just not giving a lot.
Thank you.
Thank you very much. And speaking of steroids, of course, you've been talking about it already, but I also wanted to loop in both on remdesivir and, of course, on steroids. Dr. Subramanian, who, as Dr. Rogers pointed out, has been involved with a lot of research here, along with Dr. Rohatgi and others. Dr. Subramanian, you wanted to get your thoughts on remdesivir that wasn't already covered, as well as the use of steroids and indications.
No, I totally agree with what Dr. Rogers said. I don't think people need to go out of their way. If there's a shortage of remdesivir, it's not worth paying, exorbitant amounts of money for it and getting it. I really think that steroids are much more important. I do understand that when there's a bed shortage and you want to get people out of the hospital, remdesivir can help, but it's really there's no mortality benefit with it, whereas steroids can really help in preventing mortality. But as Dr. Rogers said, I fear that, and I've heard that very high doses of steroids are being used with the methylprednisolone, and it really should be low dose and limited to 10 days, because as I said, we're seeing complications in people who are taking too much.
Thank you very much. Dr. Rohatgi, any comments as well?
No comments, Dr. Rohatgi, at this time.
Great. I want to move on.
Errol, sorry. So Dr. Subramanian just wanted you to comment on baricitinib, which as we work for, I'm from International SOS, we get a lot of requests from our clients So we've had some of these requests, and it's been very difficult. It's a very expensive medication here in India. And what is maybe you'd want to highlight on what is the role of baricitinib?
I'll let Dr. Ahuja take that because she worked on that study very.
Sure. Okay.
Thank you. Yes, myself and Dr. Nadeau worked on this study, and baricitinib is a JAK inhibitor, so it helps with the cytokine storm, but has also been actually shown to help maybe have some antiviral properties. It's an oral drug, short half-life, relatively good safety profile. So head-to-head with dexamethasone, it looks like it's about even, but may have a slightly better safety profile. The risk of DVTs, PEs was not very significantly increased with baricitinib. So I would say that if they have access to dexamethasone, that's probably the most cost-conscious approach. If they do not have access to that, then baricitinib could be used. Dr. Nadeau, do you have anything to add to that?
No, that was a perfect answer. Thanks so much, Dr. Ahuja.
And thank you for those. I also want to talk a little bit about monoclonal antibodies. It's been a very common question. Perhaps Dr. Subramanian, I could ask you to comment on what are we doing here, what are recommendations, and also Dr. Samir and others to help us understand our recommendations as it relates to what's available in India.
Right. Here we are trying to target people who are at high risk for hospitalization. So we're giving it to people who are outpatients, and Dr. Mahadevan had gone over the risk factors for people who are likely to develop severe disease, and those are the people we're really targeting: the immunosuppressed people, elderly, hypertension, cardiovascular issues, and we are bringing them in early for monoclonal antibodies. But it's, it's cost effective here. It's free for patients, and we're able to give it to them quite quickly.
Great. Any other comments from others? Dr. Ahuja?
Maybe if I could say a quick word on monoclonal antibodies, we have studied, there have been numerous studies now looking at monoclonal antibodies in hospitalized patients. So that includes, again, a lot of the patients that you're caring for at home on oxygen, or even room air. And those haven't shown benefit in hospitalized patients in now 3 different cohorts across the US. And so I think, as Dr. Subramanian highlighted, it's for very early. It's not after you've had symptoms for a really long time. It's a minor benefit. So that would be, again, compared to steroids in people who need oxygen. Often by the time you're needing oxygen, it's later in your course. You need anti-inflammatory. It may not help that much. So I would put that in if it's really early and available, great, but not worth, spending thousands of dollars trying to find, because it probably won't help, especially later when the person's very ill.
Totally agree.
If I'm permitted to, just wanted to take a small deviation, and we noted that the Prime Minister, Dr. Singh, had also been part of this, and thank you so much for joining. And he did put a question in here, if we can. We're going to keep going on treatment, but I do want to talk a little about treatment in regards to his question. The FOGSI recommends giving COVID vaccine to pregnancy lactating mothers, while our union ministry does not recommend. How do we go about this? And perhaps Dr. Nadeau would like to try and explain that. I think she actually might have disconnected a little bit. Perhaps Dr. Subramanian, any thoughts on this? This was an important question. We actually noted this one as one of our important questions to answer. So thank you for bringing this up now.
Sure, and thanks to the Minister of Health for the question. And we feel that it's important to try to vaccinate pregnant women. So far, in the studies that have been done in mRNA vaccines, it does appear safe. And pregnant women are at risk for severe disease and worse outcomes of the pregnancy. So anything we can do to protect pregnant women that's safe for them, we'd like to go ahead. And so far, it does seem that vaccination is a good idea. Some of the vaccines haven't yet been studied in pregnancy, so it's a risk benefit, but we really think that the benefits outweigh the risk. And we think that lactating women, do have an advantage
when they're if they're vaccinated, because they give the antibody protection to their newborn infants. So there is protection that they're transferring. We've had at Stanford many good outcomes from pregnancy, and we've had patients deliver their babies without problems, without getting COVID in the infant or having any complications. So, you know, it can be a positive experience.
Great, thank you very much. If there's no other comments there, I would like to keep talking more about different treatment modalities as well. We talked a little bit about monoclonal antibodies. Another common question was convalescent plasma and the role of that. I know a few of the panelists here could talk about that. Perhaps I'll start with Dr. Subramanian again.
Sure. Convalescent plasma, you know, hasn't been as helpful as we thought it would be. It can be helpful in people who can't make antibodies themselves if they're very immunosuppressed and they're early in their in their hospitalization. But it's as Dr. Rohatgi had pointed out in the very beginning, it's difficult to give at home. It's something that's, you know, can have side effects like volume overload, and it needs to be matched, you know, by blood types. And so there's a lot of problems that you can run into by giving convalescent plasma. And there's also a theory that it might be actually, if it's not high enough in the neutralizing antibody titers, that it might be selecting for variants. So we've moved away from using it routinely. We only use it in very select people, as I said, people who are immunosuppressed and can't make antibodies on their own and who are early in their course.
Great, thank you, Dr. Subramanian. Another very common question we got both now as well as before the registration was the use of ivermectin. That's been a very controversial one out there, and it's something that we've talked about a lot. Dr. Subramanian, you just nodded, perhaps I'll go to you again to comment on that.
Oh, sorry, I'm just nodding. But I would say that we don't have enough evidence, you know, for or against ivermectin. So I feel, you know, we're not routinely using it or recommending it here. And it does have potential side effects. I know it is being routinely used in many areas, but we are not using it here.
Thank you. Dr. Rogers, inhaled steroids has also been a common question, both the use of it in the hospital or in the outpatient setting. You've looked at this and studied it a lot. Can you please comment and share your thoughts about that?
Sure. You know, I think building a little bit also on the ivermectin story, I think there is a real desire when you're sick to do something and to take something. And the idea of, you know, getting sick, hearing you have COVID that has killed so many and doing nothing seems scary. But, you know, as a lot of us on this call have done a lot of science, and we find that most things we study don't work when you rigorously look at them. And in fact, they often have side effects, and we may be doing more harm than good. So I would definitely agree with with all others that ivermectin would be, I would not just take that because what if it's harming you? Inhaled corticosteroids is one that doesn't have huge amounts of evidence, but I feel like that is one that is very unlikely to harm and may help. And the reasons that I'm hopeful about it is that there are some early studies that suggest it prevents people needing to go to the emergency room or get admitted in COVID. There are also studies that have been done with that therapy actually preventing progression to ARDS in patients with bacterial pneumonia. So that's also been published. And we know that for more severely sick patients, that systemic steroids at modest doses, like we just discussed, are helpful. So for all of those reasons, I feel like inhaled steroid is unlikely to be harmful. You know, it's a very common medication that's used for asthma, widely available, and that is one that I do think if I certainly was feeling sick with, if I had some symptoms, I would consider inhaled corticosteroids, and I wouldn't recommend against that. And I hope that we will very rapidly enroll into studies to answer the question definitively. But that is one, in contrast to things like convalescent plasma and ivermectin, that I would be comfortable with. If a family member asked me, do you think I should do this? I would say, sure, why not?
Great, thank you very much. And Dr. Subramanian, another question that came up, there's a relatively new medication that will be available, I understand, soon, 2DG. Any comments on the use of that and its effectiveness in COVID-19?
Happy to comment. I think Dr. Barman wanted to say one more thing about inhaled steroids.
Oh, thank you. I was just going to comment quickly on, so outpatient management, we see a lot of people early on. We treat them to try to keep them out of the hospital. And I think it's important to remember the best thing you can do for someone with asthma with COVID-19 is to control their asthma. Similarly, for someone with diabetes with COVID-19, the best thing you can do is control their diabetes. So definitely treating their comorbidities aggressively, which frequently does include inhaled corticosteroids, is essential. I do want to remind people, we do not use nebulizers in the outpatient setting because of the risk of aerosolization and spread. If someone's having difficulty, we actually really highly push spacers, which make the inhalers much more effective. And one last thing, I'd encourage for treatment in an outpatient setting, and it sounds very basic and boring, but first, make sure you know what medications they're taking and what they're actually taking. I am shocked by how many of my outpatients, when they get diagnosed with COVID-19, they stop their diabetes medicine. Maybe they stop their inhaled corticosteroid they're supposed to take for asthma. They'll stop their insulin. I don't know why, but the best thing we can do is keep people well controlled.
Gotcha. Thanks so much, Dr. Barman. And Dr. Subramanian?
Oh, about the 2DG, yeah, that was developed by DRDO. I don't have direct experience with it, but there is phase 2 and now phase 3 top-line data that does show it may help people get off of oxygen faster. It inhibits glycolysis, so it sort of helps reduce inflammation, and is the theory is that it helps reduce the damage caused by SARS-CoV-2. I think the studies are pretty early still, but I was given emergency use authorization in India, so I'm looking forward to seeing more data as it comes out.
Great, thank you very much. I want to go to the next question. Dr. Ahuja, talking about the inpatient management of a typically hospitalized COVID patient, someone who's not in the ICU. We talked a little about measuring labs and markers. How frequently should we be measuring these things? Does it matter so much? And also things like the inflammatory markers, the ESR, CRP, and actually perhaps Dr. Rohatgi can also comment on this as well as inpatient doctor, Dr. Rogers as well.
Hi, sorry, I can answer that question. Inflammatory markers need to have a clinical correlation. So while we have seen a correlation between D-dimer, CRP, and at times some of the acute phase reactants, it really needs to be correlated with the symptoms of the patient. So some people recommend trending the D-dimers, but we haven't really found that to be helpful as long as we know that their respiratory status is okay, et cetera. So given that resources are limited, nurses are stretched, patients don't need to give blood unnecessarily, we would say not to trend it and just go with clinical.
Great, thank you. And speaking about the inpatient management, we want to also talk about both the general inpatient and the critical inpatient management. One thing we didn't touch on in treatment that we want to talk about is anticoagulation, blood thinners. Perhaps Dr. Rogers can comment on that as well. What patients should be getting it in the hospital, and perhaps also should patients that aren't hospitalized need it as well?
So this is a hard issue, and I would say there's not a clear answer. There have been a lot of studies. A number of us have been involved again in studying these questions in our patients. And I know that in the United States, just like in India, there are a lot of hospitals where people say absolutely everyone needs to be on a blood thinner, and other hospitals where it's not the standard of care. And that's why we study these questions. There will be studies coming out that suggest that it probably does have some benefits in non-ICU patients, and ICU patients actually showed a trend toward harm because of bleeding complications. In non-ICU patients, it may have a trend toward helpful, but you're at home. For most of these sick patients are at home. They can't respond easily to bleeding. And so from my perspective, and I would definitely love to hear the input of some of the other inpatient doctors, that I would say that probably based on the evidence we have now, that the risk benefit ratio is not there for being at home and taking full anticoagulation outside a hospital setting, even if you are quite sick and on oxygen, unless there's some other reason that you are supposed to be on a blood thinner, like atrial fibrillation or a known blood clot. Of course, then it's different. But that would be my thought. I'd be curious from others.
I completely agree with Dr. Rogers. That's been our recommendation as well, given our inpatient experience, and then when we discharge patients home.
Dr. Subramanian, any comments as well?
No, I agree with everything that was said.
Great, thank you very much. I want to pivot a little bit over now to vaccinations. It's been a topic that perhaps along with treatment has gotten the most questions about that. And again, I'm very happy that we have Dr. Nadeau with us to talk to us a little bit about vaccinations. Dr. Nadeau, can you comment a little bit about, so you've been for the last year teaching us about vaccines, particularly the ones available to us. Can you comment a little bit about vaccines in general, perhaps also the ones that are currently available in India, the ones that are expected to be available as well in the near future?
First, let me say to all of our colleagues and people in India and families that we are there with you. We're many thousands of miles away, and it is a pleasure and an honor and a delight to be with all of you. And we feel humbly happy to answer questions, but importantly is that we want everyone to get vaccinated. India has 4 vaccines now that have been approved in your country. That's excellent. And most importantly is make sure that you get them and that they're accessible to all of you and your families. And so the vaccines that are there in India right now are the 4 are AstraZeneca, which is available in 148 countries, including India. Covishield, which is available in many countries, including India. Covaxin, only available in India right now. And then Sputnik 5, which is available in 35 countries. Sputnik 5 was just approved and available in India today. So I think that's excellent that you have these choices. Every single one of them has shown good and excellent effect against COVID. And there are variants, and I know a lot of you have had questions about that, but importantly is any vaccine is going to be better than no vaccine against any variant. And why is that important? That's because, as Dr. Rohatgi mentioned, that we have already many pieces of data to show that vaccines can give you protection, and that level of protection can at least keep you out of the hospital. And that's what we're all trying to do. A little mild infection is fine. The rate of getting COVID after vaccination is only 0.007%. So vaccines are critical, and people really need to get them to be able to help their health. You can take them when you're pregnant, you can take them when you're lactating, and importantly is, as of yesterday and Monday, they have been shown to be effective against the India variant. The India variant is called B.1.617, and it's highly infectious. And for that reason, everyone in India should also get vaccinated. But luckily, the vaccines have helped that variant.
And Dr. Nadeau, thank you for that. And we had lots of people wondering those very questions. There's a theme of some questions. So a lot of the physicians are working hard to make sure everybody understands that vaccines are helpful. Any potential risks are much higher not getting the vaccine than getting it. And then families and patients who have messaged as well are asking that question. What can you tell to physicians in India? What advice would you give them to help spread this message that you just gave about how valuable it is to get a vaccine?
Yes, I think that in the very beginning, and of course, as we're all talking about and what India is dealing with right now are very acute COVID cases that are overwhelming the hospital system, overwhelming the population. But what we have also been seeing in China, in Korea, in the US, in countries around the globe is the burden of long-term COVID. And we have now people in the US now a year later that have long-term issues. So we can't forget about the burden of disease and that we should not be cavalier. We do not even want asymptomatic or mild disease if we can try to prevent it with the vaccine, because the long-term consequences are, I believe, also very burdensome to one individual and to the public health system. And people have cognitive issues, they're very tired, they can have breathing issues. Dr. Barman has been taking care of these patients, as well as Dr. Subramanian and others. So we've learned a lot, as well as our global colleagues, but I just want to really stress that taking the vaccine can also very likely prevent those long-term symptoms as well as acute symptoms. So it's good for both. And many people ask, well, if I already got COVID, do I really need the vaccines? And yes, absolutely, you should get the vaccine, and you should wait about 3 months if you can wait. But most importantly is get the vaccine. And if you got COVID, that doesn't necessarily mean you're protected. And even if you got the vaccine at this current time, you should still wear a mask. You should still stay 6 feet away as much as you can to get away from people that could have an infection, because that helps the community as well.
Dr. Nadeau, there was a lot of comments on how people are getting COVID around the time they get their first vaccine. One, it has been to clarify, it is not, of course, related to the vaccine. There's been some concern that people are going out and being around people and getting COVID just coincidentally when they get the vaccine. Is that true?
Yeah, it's just a coincidence, but most importantly is to get the vaccine. The best vaccine is the one in your arm. So please know that I know we tend to try to convince people that maybe one is better than the other. It doesn't matter, just get the one. All of the vaccines right now have been better than 60% effective, which is what we were shooting for last year this time. So I think you have some great vaccines in India. They should be used without any hesitation. And even if people are on medications, immunosuppressive medications, cancer medications, we are still vaccinating people like that in the US. And that's important. Even any sense of immunity, any extent of immunity is better than nothing.
There's a lot of questions about asking which is the best vaccine for me. You just said the best one's the one in your arm. That seems to me that any vaccine someone can get, they should get it and not wait for another one.
Yes, exactly. And then it is possible to mix. I know Dr. Rohatgi mentioned that. We, in working with the FDA recently, as well as the WHO, it is fine to mix them. Most likely we will need boosters, and that will be done later on, but most importantly is get the vaccine. And if you need to get a second one and it's a different type of vaccine, that's fine.
Excellent. Thank you. Dr. Nadeau, that was excellent. Any other thoughts or comments about vaccination? It's such an important topic from the rest of
Yeah, Errol, just wanted to add to what Dr. Nadeau said, was that the Indian government guidelines currently say that if you are infected with COVID, you have symptoms, you wait for around 4 to 8 weeks. I think in the West it's around 3 months. So that's a slight difference here.
Yes, thank you. Thank you very much.
Great. Moving on.
And even if you, one other point, sorry, if you have to wait longer, if it's not possible, if you have a longer time period between the first and second, it's okay, go ahead and get your second dose.
Yes.
You still will get very good responses.
Thank you. As we transition to the next topic, we have about roughly 10 minutes left. I want to thank the panelists as well. We've had a number of questions coming through live as well. We're trying to answer the live ones as well as the ones pre-answered. We've had 118 of them answered in writing as well. So please also look through that as well, and we'll try to make that available to you. So thank you to the panelists for answering that. A little bit on diagnosis using high resolution CT scans, which we know is very commonly used in India. Dr. Ahuja, can you comment a little bit on that and the role of it and the value of it?
Certainly. Thank you, Dr. Ozdalga. So a high-resolution CT scan should only be ordered if a patient is clinically deteriorating for an unexplained reason. So if the patient is on oxygen, not improving with oxygenation, and you're worried about either ARDS or worsening pulmonary infiltrates or a pulmonary embolism, which may require the angiography component to the CT, that's when it's indicated. Otherwise, a chest x-ray or really just clinical symptoms, given how limited resources are, would be adequate. In the US, we are using a point of care ultrasound at times when we can. I understand that that is not as readily available, but we hope that given the cost effectiveness of that, that might be a more readily available resource in the future.
Thank you. Dr. Rogers is a lung specialist. I also want to get your input on this as well. Any other, from your perspective, any other things to consider about using CT scan?
No, I agree 100% with Dr. Ahuja. That for most people, it's not necessary unless you have a question about something other than COVID. I do understand that sometimes the turnaround time for the nasal swab can be many days. And so if it's easier to get a chest x-ray and that looks consistent, it happened here that when we were in our major surge, when it seemed like COVID, it was COVID. And unfortunately, that's probably what you're going through too. So if you have classic symptoms and a chest x-ray that looks like it, I would not get a CAT scan as well. I agree with her 100%.
Thank you. Dr. Maha, one of the questions we actually saw quite frequently was the question of why during this wave are there so many, it seems like there's so many younger people in their 30s, 40s dying than there was earlier. What thoughts do you have of that's going on in regards to that? No, you're muted.
Yeah, so Errol, definitely, well, anecdotally, I've heard this from many friends, family, and colleagues in India. It's really hard to make this inference without having the hard data. If we were to go by the data that was provided by the COVID India task force during the first wave, 31% of patients under the age of 30 were affected. And in the current wave, they say 32% of COVID patients are less than 30 years of age. So part of the reason that people may be feeling this way about the younger patients is that the total number of affected individuals in this particular wave in India has been higher. And so following that, more overall people less than 30 are probably been infected. And also, if you look at India population as a whole, it has a higher percentage of younger patients. I believe that 45% of the Indian population is less than 19 years of age. So it's a younger population overall. And this has certainly impacted the overall numbers of deaths in younger individuals as potentially more infectious variants lead to more overall infections.
There could also possibly be another reason, like we saw in the Spanish flu. If you're young, you've got a very good immune response, and possibly that brings in the cytokine storm with a vengeance. You have all the, you tend to have more effects of the cytokine storm because you've got a very good immune response, less so with the elderly population.
Just one more thing, and this relates to the sheer number of infections that they're seeing in India, which is basically overwhelming the system. And that is in mildly ill individuals who might only need supplemental oxygen and steroids to survive COVID, to get through this infection. They may be dying at higher rates now because they just can't access medical care. And these we would consider potentially preventable deaths. We know that our colleagues in India are doing everything they can to save these patients, but this is the same thing that happened in Wuhan, China, before they were able to get clinical resources and infrastructural resources to address the situation and bring down the mortality rate.
Yes, Dr.
Thank you so much. There were some questions about side effects of the vaccine. I can say, after having taken care of many people who got the vaccine, the side effects do not affect the efficacy of the vaccine. And we expect people to get fevers and headache and aches after the vaccine. That is okay to have. And we want to make sure people know that the the benefit is way far better than the risk of the side effects that are very temporary, and they do not affect the efficacy of the vaccine. And if you get the vaccine and you have no side effects, you can still have the vaccine work. So that's very important. And the risk of any major side effects is very, very, very small.
Thank you, Dr. Nadeau. As we get closer to the end, we did want to talk a little bit about mucormycosis. That's been a common topic that's also come up recently. Dr. Subramanian, could you please tell us a little bit about that in regards to COVID-19?
Sure. It's a really rare fungal infection that we see in people with low immune systems or people whose blood sugars are out of control. And it's become more common now in patients who have had COVID-19 because I think we're seeing high use of steroids, sometimes overuse of steroids without controlling the blood sugars. And steroids themselves do cause immunosuppression, especially when you give them long-term or at very high doses. So that was what I was trying to talk about, really sort of limiting the use of steroids to those who really need it. Controlling blood sugars is very important. And what should you look out for? People are quite nervous about it. If people develop a sinusitis and they have any black or dark discharge from their sinuses after they go home, it's usually after you're recovering from that acute COVID episode. It can start in the sinuses and go back into the brain. So it's something that really needs to be looked into quickly. It can affect the lungs as well. If somebody's coughing up blood, it's a bad sign. And so, and what should you do about it? Really, the thing to do is to involve surgeons quickly. ENT surgery specialists are the ones who do a lot of the debridement, and surgical debridement is the treatment of choice. Antifungal medications can be very caustic. They are just adjuncts to the surgical treatment, but really sort of getting it early, watching for it, trying to do things to prevent it are the best way to go. This fungus is something that's in the soil, it's in decaying fruits and vegetables, it's all around us. So we're all breathing it in, and it's only people who are at risk who develop the actual infection.
Thanks so much, Dr. Subramanian. As we hit the end of this hour, I want to thank all the panelists for being here. And just, I'm going to turn over to Dr. Rohagi. I just want to say thank you to everybody. And on behalf of Stanford, we're here for you all. And we wish you the best. Dr. Rohagi, will you please say a few words before we end?
Thanks, Dr. Osdalga. I really want to thank everyone who was able to join us for this webinar today. And I hope it was a helpful discussion for you. Over the next few days, we will continue to work through your questions and provide answers through the Stanford Global Health website that I put in the chat. We will also post a recording of this webinar and the treatment plan that I discussed earlier for mild, moderate, and severe illness at home and in the hospital on this website also. So you will be able to download those treatment plans. If we host any other events, we will announce it through this website, and as well as we will post it on the Twitter channel for the Stanford Global Health. Thank you again to our expert panelists and Dr. Osdalga and Dr. Dwivedi for joining us from India. Take care, everyone.
Thank you.
Thank you, everyone. Bye-bye.